Welcome to the Spark Live webinar series, one component of our Spark Knowledge Mobilization Program. Spark is Children's Healthcare Canada's shared platform for advocacy, research, and knowledge. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live bi-weekly webinar series. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box visible to all of our attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark News e-bulletin by visiting our website at childhealthcan.ca. Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. This month, the Spark theme relates to pediatric pain management. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We recognize and deeply appreciate their historic connection to this place. We also recognize the contributions that Métis, Inuit, and other Indigenous peoples have made in shaping and strengthening this community, our province, and the country. Today, during Spark's Pediatric Pain Management Theme Month, we're delighted to partner with our colleagues at SCIP to bring you Pediatric Pain, Patient and Community Partnership, and Research, 5 studies to keep you in the know. Before we begin, I would like to thank Dr. Katie Burney for assisting us in selecting this superstar group of panelists. Today, we have a great group of researchers joining us with novel findings from their Chronic Pain Network-funded projects. I will introduce each of our speakers one by one prior to their respective rapid-fire presentations. Just a reminder that we record all our webinars, and as mentioned in the introductory video, please type your questions into the question box at any time, and I'll prompt you via the chat as well. And I'll pose your questions at the end of all presentations today during our live roundtable Q&A. It's now my pleasure to introduce our first speaker, Dr. Sabine Soltani. Dr. Sabine Soltani is a clinical psychologist and postdoctoral fellow at the University of Calgary. She completed her PhD under the mentorship of Dr. Melanie Knoll at the University of Calgary and completed her postdoctoral residency with the Calgary Clinical Psychology Residency Program in 2020. With the support of a Louise and Alan Edwards postdoctoral fellowship in pediatric pain, Sabine is continuing her research in the area of pediatric pain with Dr. Knoll as part of the Pain Education, Advocacy, and Knowledge, or PEAK Lab. Today, she will be presenting on her work titled Trauma and Pain, an Intergenerational Problem. Over to you, Dr. Soltani.
Thank you so much for the great introduction. As mentioned, I am a postdoctoral fellow working with Dr. Melanie Knoll, and I'm honored to be here to be able to present some of the research that we are engaging in with the support of the Chronic Pain Network. To begin with, we know that pediatric chronic pain is a highly prevalent concern, affecting as many as 1 in 5 youth. And we also know that the chronic pain experience isn't just about pain. It often co-occurs with a range of mental health concerns, which can be very impactful for youth and their families. One of the areas that we have focused on in our research is the connection between trauma, symptoms of post-traumatic stress disorder, or PTSD, and pain. While we've known about this connection in the adult world for years, there is now accumulating evidence in the pediatric world, similarly showing that trauma, PTSD, and chronic pain also co-occur at high rates in children and adolescents. Importantly, we're finding that trauma symptoms are meaningfully related to pain outcomes. They're associated with worse pain and functioning and can impact response to psychological interventions for pain. Conceptual models have proposed a range of cognitive, affective, behavioral, neurobiological, interpersonal, and developmental factors that might help explain the PTSD pain connection. So these are factors that might serve to mutually maintain both conditions. And these are what we really wanted to understand in our research. The idea was that if we could better understand the shared modifiable mechanisms underlying trauma, symptoms, and pain, maybe we can do something about this and really tailor treatment to enhance outcomes for kids who had these co-occurring symptoms. So with funding from the Chronic Pain Network and in collaboration with patient partners, we embarked on a study which we call the Pain and Mental Health in Youth Study, or the PATH study for short. This study is a big one, and it has morphed over the years into a multi-year longitudinal research program. It involves looking at kids coming into the tertiary chronic pain program at the Alberta Children's Hospital. And to date, we've had over 200 kids and their parents participate in this study. When they come in, we gather all kinds of information. We conduct diagnostic clinical interviews to assess for anxiety, depressive, and PTSD symptoms. We do daily activity tracking of mood, pain, general activities. Participants complete tasks like eye tracking to look at attention and other cognitive biases, as well as we do brain imaging. We do genetic testing using saliva samples. We assess sleep disturbances and sleep-wake patterns. We assess for adverse childhood experiences, or ACEs, parenting responses, and a range of other cognitive, affective, and psychological factors. We then follow up with them 3 months later to reassess for pain and mental health, to really look at how these factors might influence and or maintain trauma and pain over time. From an intergenerational perspective, what's really great is that we're assessing many of the same constructs and symptoms in parents as well, many of whom have chronic pain themselves. So for the purposes of time, I'm just going to highlight one piece of this PATH study puzzle. Oops, there we go. So one of the areas that we focused in on was sleep. Sleep is a key factor that we think is related not only to pain, but also related to PTSD, and an important factor in the co-occurrence of PTSD and pain. The data I'm presenting here is from a paper stemming from the PATH study data that was recently published in Pain. What these findings showed was that pain interference, or the degree to which pain interferes with everyday life, and PTSD symptoms both predicted worsening pain interference at 3-month follow-up in these kids. So higher pain interference at baseline is associated with worsening interference at follow-up. But even controlling for that, kids with higher PTSD symptoms coming in are showing a worsening of their pain interference over time. In addition, sleep disturbance mediated the relationship between baseline PTSD symptoms and follow-up pain interference. So this co-occurrence of PTSD and pain was in part explained by the fact that these kids were experiencing significant sleep disturbance. This is important because trauma and symptoms of PTSD are something that we don't often feel comfortable assessing for. But what this study is suggesting is that these symptoms are important and are potentially impacting outcomes. These findings suggest that we have 2 factors here, sleep and trauma symptoms, that may be important to consider in comprehensive assessment and treatment for pediatric chronic pain. So I'm almost out of time here, so I'll just quickly end by wrapping up and thanking you for having me, and a big acknowledgement to the Chronic Pain Network and my amazing mentor and lab. Thank you.
Thank you, Sabine. I have one question before we go, and it also serves as a reminder to others to type their questions in as they think of them, and I'll take questions from the floor at the end of all the presentations. But Sabine, how can care be modified to buffer against the adverse effects of trauma or on pain?
That's a great question. I think One possibility is to assess for trauma and symptoms of PTSD to see if they're present in the first place. I would say the same goes for sleep disturbance and insomnia. I think this can help inform why some kids may or may not be getting better and allude to some of the important co-occurring concerns that can have an impact on treatment. And we have evidence-based psychological treatments that can help. So we have short-term interventions for insomnia that we know work. And if we treat sleep issues, I think that this is likely to have a general positive impact on mental health and pain. And I think can help promote some better traction with chronic pain treatment for kids who are experiencing those co-occurring concerns.
Thank you, Sabine. Next, I'd like to welcome Dr. Krista Berg to the mic. Dr. Berg is a consultant pediatrician and associate professor of pediatrics at the University of Saskatchewan. She's the medical lead for interdisciplinary pediatric complex pain clinic at Jim Pattison Children's Hospital and is a pediatric site lead for the Chronic Pain Network. Dr. Berg will be presenting on complex regional pain syndrome in Canadian children and youth. Over to you, Dr. Berg.
Thank you. Thank you for that introduction. First, I'd like to just acknowledge that I am in Saskatoon on Treaty 6 territory and the homeland of the Métis. And so I would like to pay respects to the First Nations and Métis ancestors of this place and reaffirm my relationship with them and with one another. So the objectives identified for today were to summarize the key outcomes from the Canadian Pediatric Surveillance Program study and to just provide a quick approach to assessment of pediatric complex regional pain syndrome, or CRPS, in the office. Complex regional pain syndrome often follows injury. The pain in the affected limb extends beyond any peripheral nerve distribution, and it's a clinical diagnosis based on diagnostic criteria. There's 4 key categories or domains that are affected: sensory changes, vasomotor changes, pseudomotor changes, and motor trophic changes. So children will present with severe pain and amplified pain, pain with touch, light touch, or a little bit of pressure, vasomotor changes like temperature, asymmetry, color changes, swelling, changes in sweat, and also motor trophic changes. So changes in how the limb works, weakness, tremor, dystonia, or even changes in the hair, skin, and nails. It's important to identify complex regional pain syndrome and to just be aware of some of those unusual symptoms so that one might think of it when a child is having continued pain. So this study was done because CRPS is a rare but debilitating pain disorder. Early diagnosis is associated with better outcomes, and very little is known about how common pediatric CRPS is in Canada or how Canadian physicians manage it. So the aim of this study was to describe the minimum incidence of pediatric CRPS, the clinical features and treatments recommended by Canadian pediatricians and pain clinics. This is a 2-year surveillance study undertaken in collaboration with the Canadian Pediatric Surveillance Program. 198 case questionnaires were returned to us, and 168 of the cases met the Budapest clinical diagnostic criteria. We asked clinicians to report any children with a new diagnosis of CRPS aged 2 to the 18th birthday. Approximately 2,800 pediatricians across Canada actually participate in this program monthly, so it's a very well-established program. And during the 2-year study period, all 11 Canadian pediatric pain clinics also participated. We found that the annual incidence of CRPS is 1 per 100,000, and that girls are more commonly affected with a mean age of diagnosis around age 12, and a median time from onset of symptoms to diagnosis was 6 months. Most commonly, the lower limb was affected, and most commonly, one single site was affected. Most children had moderate to severe pain, and 1 in 5 had no known cause or inciting event. The most common referrals were to physical therapists and multidisciplinary teams. Looking at the functional impact that was reported by the clinicians reporting cases, the most common functional impairment was with physical activity, affecting nearly 95% of children. Next most common was sleep, impacting social activities, school attendance, and less commonly school achievement. Also mood and family function. Treatments. Well, we wanted to look at the 3P approach, including physical, psychological, and pharmacologic treatments. We found that desensitization and fitness programs were most common. More than half of children received pain education and psychological strategies, and that non-steroidal anti-inflammatory drugs and acetaminophen were more commonly prescribed than anti-epileptic drugs and antidepressants. So we did wonder if perhaps physicians were relying on ineffective treatments for children. We did have a patient partner involved, and she was involved in all phases of the project. She supported the grant application, helped refine the study question, helped interpret the data, and reviewed the manuscript. She also ensured that we captured relevant information on functions such as impact on school attendance and school participation, as well as treatment side effects. In terms of everyday practice, I think it would be helpful to review the International Classification of Disease 11th revision that will be coming out in January. It has a really nice summary of the diagnostic criteria of CRPS that will be coming into effect, with lots of details on how to assess CRPS, as well as some clarification of some of the language that was a bit ambiguous in the past. It's also really important for clinicians to systematically ask about all symptoms and look for each sign at each of their formal diagnostic evaluations, so that you can characterize how CRPS is developing over time and be sure to identify it early if possible. When pain extends to other limbs in the body, it's also important to apply the full diagnostic criteria to each limb, because it is common for patients to go on to develop chronic pain in other limbs without having CRPS spreading. This is just a quick summary of some of the changes that are coming out in the ICD-11 criteria, which has a little bit more detail for diagnosis compared to the Budapest criteria. They've also identified persistent pain recurring longer than 3 months, so they've given a time frame for diagnosis, which will be helpful, clarified the signs and symptoms, and added a functional indicator such as emotional distress or interference with activities of daily living. So in conclusion, pediatric CRPS more commonly affects girls, the lower limb, and occurs at a single site. The incidence is rising after age 12, and the average age of onset is age 12. Treatment variability is common, so a treatment path might be helpful to support consistent practice, and maybe a screening tool could improve identification as clinicians are working in the office. I just wanted to acknowledge all of the people involved with this project. So all of the pain clinics participated in reporting, and this project would not have been possible without each person's involvement. So it was a great opportunity for collaboration across the country.
Thank you, Dr. Berg. Based on the results from this study, what do you think are the most important next steps?
Well, I think considering all of the treatment variation that we saw among patients, it would be helpful to have a clinical pathway for clinicians to follow in terms of a summary of evidence-based treatments and recommendations, and some guidelines for treatment in Canada. It would also be helpful to have a screening tool that could be used at the bedside, because it is cumbersome to try and remember all those criteria.
Always more work to do following a study, isn't there? Thank you, Dr. Berg. Now we welcome Dr. Chitra Lalu. Dr. Lalu is a digital health researcher at the Hospital for Sick Children and an assistant professor with the Institute of Health Policy Management and Evaluation at the University of Toronto. She is research lead for both the iCanCope pain self-management mobile health platform and the Pediatric Project ECHO clinical education program. Dr. Lalu has overseen the creation and growth of the iCanCope platform for youth with chronic pain, arthritis, sickle cell disease, postoperative pain, and neurofibromatosis. She's leading multiple innovations to streamline and optimize evaluation of digital health interventions, and she'll now present on the iCanCope, a digital platform self-management program. A digital pain self-management platform for youth with chronic pain. Over to you, Dr. Lelou.
Hi, good morning. Thank you for the introduction. Really delighted to be part of this panel today. So iCanCope is a smartphone and web-based pain self-management platform for young people living with different types of pain. It's designed to empower users to better understand their condition through disease-specific education, to develop and practice healthy pain coping strategies, and to receive social support from their peer group. iCanCope creation and evaluation has been guided by a user-centered design framework. So starting on the left, we begin with needs assessments, so that's qualitative studies, to better understand the pain self-management needs of our target end users, who are young people living with pain. Next, in the design phase, the core features were scoped and then underwent usability testing to refine the prototype and make sure it was easy to use, easy to understand, and intuitive. And we're now in the evaluation phase, seeking to test the program in the target users and setting. So providing a bit more detail, our needs assessments involved focus groups and individual interviews with youth living with chronic pain and healthcare providers who treat them from both the pediatric and adult healthcare settings. The aim was to identify the pain self-management needs of this group. In terms of the results, all of the participants, so both the youth and the healthcare providers, indicated that a program such as iCanCope could help to improve access to youth-focused pain education and self-management support. And they specifically endorsed 4 core features for the program, which are shown here. So symptom tracking, goal setting, a coping toolbox, and social support. So iCanCope is a collaboration between SickKids and as well as 2 groups who are our development partners. So eHealth Innovation at University Health Network is the developer of the app, and About Kids Health at SickKids is the developer of the iCanCope website. So in the design phase, interactive sessions were run with youth with chronic pain, members of the app and web design teams, as well as members of our research team. The design team ran what are called time of day exercises, asking youth to describe a typical day in their life and all the moments when pain often would get in the way of something that they wanted to do. The group then brainstormed to think about ways that a digital program could be designed to support them in those moments of pain. These exercises also generated 3 core design principles for the iCanCope platform, which are shown here. So keep it simple, help me support my life, not just my pain, and a friendly and safe space for me. So lower and higher fidelity prototypes were then created and underwent usability testing. And this was to really try and refine the intuitiveness and the design of each of the key features, which are again just summarized there. This is the final feature set for the iCanCope mobile app, which has been developed for iOS and Android devices. Informed by one of the design principles, which was a safe and friendly space for me, the program features a character or an avatar called Copy. So that's the blue character shown here. And Copy guides the user through the whole app experience. So they will celebrate if you have success, so if you achieve a goal, and will provide advice in moments of pain. Looking a little closer at each feature, so the CheckIn is the conceptualization of the symptom tracking feature, and it provides users with the opportunity to document their daily function on 6 key areas. And those are pain intensity, pain interference, sleep, mood, physical activity, and energy. Each check-in takes about a minute to complete and has been lightly gamified using Copy. You might also notice that the language of the check-in is purposefully casual and friendly, so it was meant to be non-clinical. So for example, the midpoint of the scale shown in the middle is like meh, in terms of like what was your level of physical activity today. After completing a check-in, a review screen is displayed. So if the user is doing well, they get a positive message of reinforcement shown on the left. And if they're having trouble in some areas, then they get an oh dear message, and then Copy would provide specific suggestions that may help them to improve. Trends is where users can visualize all of the check-in data that they've entered into the app over time. And this feature is designed to really help users to identify trends between their different areas of function. So for example, they might notice that if their sleep has been poor for a few days, then their mood or their pain might be worsened. So this is meant to really empower them with the information they may need to encourage them to try and make changes in their habits that could improve their pain and their functioning. Goals is where users can create and track personalized goals to improve their function. So they would first select a category that they wish to work on. So for example, sleep. And then they can either write a sleep goal from scratch, or they can choose from a bank of about 50 pre-populated goal suggestions. And then the app can send them push reminders about their goal and help them to track progress over time. And the library is the implementation of the coping toolbox. So it contains about 100 short articles, each related to a different aspect of pain education or a specific coping strategy. And then lastly, the community is a forum within the app where iCanCope users can interact by responding to a question of the week. So some of the questions are about sharing coping strategies. So for example, what's your favorite distraction these days? And others are just for fun. So a couple of weeks ago, we had, what's your costume for Halloween? So that's sort of the tone of the community. So in addition to the app, we have a complimentary iCanCope website, which was designed by About Kids Health to have a similar look and feel to the app. And the website contains more detailed pain education and coping tips. And we have also a fairly robust system in place for capturing user-level engagement data for the program. So the app is connected to a custom analytics platform called Abstract, which was developed at University Health Network. And this tool allows us as researchers to identify high-level trends and how users are interacting with each app feature. And for the website, we use Google Analytics for the same purpose. iCanCope has been built as an adaptable pain self-management platform. So we currently have multiple disease-specific configurations, which are shown here. And our largest trial is focused on chronic pain. So I'll just briefly tell you about that study. So this is an ongoing chronic pain trial funded by the CPN and is actively recruiting across 10 hospitals in Canada. The study is a 2-arm RCT with repeated measures, and participants are randomized to either the iCanCope intervention, which is the app and website that I showed you, or an attention control condition, which is a version of the app that only has symptom tracking and a website that only has pain education for a period of 2 months. And our outcomes of interest, which are shown in the bottom right, are assessed at baseline, 2 months, and 6 months. So in terms of status, we've currently randomized 296 out of our target of 300, so we're very close, and recruitment will be closing at the end of November. After the collection of the follow-up data points, the trial analysis will be completed. Just for reference, these are our iCanCope publications to date, organized by condition and different methodologies. And just to close, I wanted to flag an open study opportunity for young people living with chronic pain in the community. So we have a research kit-powered study that seeks to evaluate the app in 12 to 18-year-olds with chronic pain. The study is using community-based recruitment, so interested youth can download the iCanCope Crew app onto their phone, enter an access code, which is Citizen Scientist, screen for eligibility, and self-enroll into the study. And all of the study activities happen remotely from the participant's phone, and they have the opportunity to earn volunteer hours. So if anyone is interested or knows a young person who might be interested, there's more information at the link provided. And I just want to acknowledge our funding sources for this study, as well as the members of our research team and Dr. Jennifer Stinson, who's the PI for this work. Thank you for your attention.
Thank you, Dr. Lalou. What were some of the challenges of conducting a multi-center RCT to evaluate iCanCope?
That's a good question. I think one of the biggest challenges was just getting all of the infrastructure in place. So getting all the legal agreements and all the REB or ethics approvals at all the different 10 sites. So just to get the ball rolling, and then just making sure that we were being consistent in terms of the protocols at each site, and just making sure we were very organized as the lead site to get the study going.
Wonderful. Thank you again. Next, we have dual presenters, Dr. Margot Latimer, alongside family partner Angela Naveau. Dr. Latimer is a settled Canadian with Scottish ancestry and a professor in the Faculty of Health and cross-appointed to the Department of Medicine at Dalhousie University. Her clinical experience has been in child and family tertiary care settings, prior to transitioning to post-secondary education and research roles. She holds a CIHR research chair in Indigenous health nursing and a scientific appointment at the IWK Health and faculty at the IWK Center for Pediatric Pain Research. She works closely with community to mobilize Indigenous knowledge and co-leads the CIHR-funded research Aboriginal Children's Hurt and Healing Initiative with Mi'kmaq Health Director Sharon Rudder. Angela is an Anishinaabe Bear Clan and a member of the Matagami First Nation in Northern Ontario. Angela began her journey with the Aboriginal Health Centre in 2004 and is dedicated to the health and well-being of the Indigenous community. Angela's passion and commitment to the individuals and families of her initiative ensure their access to quality healthcare through partnerships, advocacy, and a patient-first approach. Angela is dedicated to aligning Indigenous practices and ways of knowing and being to enhance healthcare experiences and relationships for Indigenous people. In substitute of a live presentation, Dr. Latimer and Angela will be sharing a video that showcases their work on Aboriginal Children's Hurt and Healing Initiative, National Gathering, and sharing knowledge to improve Aboriginal children's pain assessment and management.
Indigenous health is embraced on 4 dimensions: emotional, physical, mental, and spiritual. And as pain clinicians and researchers, we haven't been taught to think about pain in that way. And so really just want to shine a light on sort of that way of thinking for Indigenous people, and wanted to pass it over to Angela just to comment on her own participation as a community partner, because that's how this work is so meaningful, is the communities are taking the lead on this research.
Thank you, Margot. Creating safe healthcare spaces to engage our children and youth in meaningful hurt and pain conversations is an important way to promote health and mitigate the harmful impacts of intergenerational trauma as a result of social inequity. The research project examined how our Indigenous children's pain is experienced, expressed, interpreted, assessed, and treated. The research project embraced the strengths of traditional and Western knowledge holders with a 2-eyed seeing approach, which embodies both traditional and Western worldviews. It's important for research teams to create research projects that align with our Indigenous ways of knowing and being. Relationships are the foundation of how we provide services with our patients, community, and our partners.
I think that this is an amazing organization because we offer such an array of services and supports for all folks, from transportation to group activities to primary care, access to traditional healers. We do a number of things around mental health and addictions and homelessness. So this is a very well-rounded organization, and I'm very proud to be the executive director.
How are you doing this morning? Awesome. Welcome to our health center. Thank you so much. Welcome to Dejwada Desne, our Aboriginal Health Access Center. We provide culturally safe and relevant services for the Indigenous community. The translation of our name, Dejwada Desne, in the Cayuga language embodies the concept of taking care of each other amongst ourselves. In our clinic, we have nurse practitioners and physicians. As you can see, we've labeled our clinic rooms with clan animals as an identifier to incorporate our culture. Our clinic rooms are larger to accommodate appointments with families, individuals with assistive devices, and parents bringing in children.
So I'm a nurse practitioner in primary health care, and I've been with the Dejwada Desnes for almost 6 years now. I'm continuing to learn things every day. I think I learn the most from the patients and what their experiences are, what their struggles are, what their courage, and what the positive things that they're bringing to the community and to their families. So I've always learned more and more about kind of looking at health from a more holistic perspective. I remember in my first week, and a patient had come in. They were in a bit of crisis and some distress, and they had asked me, "Do you have something that I can hold?" I didn't know what they actually meant, but later that patient actually taught me a bit about they wanted something to, whether it was some sweetgrass or whether it was to have a smudge or to have something sacred that they felt to hold on to. And so ever since then, I always have sweetgrass, I always have sage, and so I always try to have something here.
The image of the health center itself was they had meetings with local elders when we first opened, who guided us in what they wanted or what the community needs were for the health center. The foundation of how we provide services is relationships and understanding our patients and their story, using their story in the way that we provide care. Being able to provide traditional health services through ceremony and healing also addresses the emotional, mental, spiritual, and physical needs of our people. This is our we call it our traditional healing program space. This is where most of our community programming happens in the evening, our circles, our teachings, our groups. Our health promotion team on average hosts 50 events per month between our locations in Hamilton and Brantford. They feed the participants at every single program or circle that they host. We use medicines and we burn sage. We have tobacco available, cedar and sweetgrass in all of the programming and traditional healing spaces.
I want to welcome you to our traditional healing room. This room is very important to us here at Idiopathic because it's really about the traditions of our peoples, and it's a safe space where people can come, they can meet, they can be treated, as well as they can share. And people know that when they come in here, racism is left outside the door. We have in this room our medicines and access to a number of different treatments, so it's very warm, welcoming, and inviting for our folks. The amazing thing about Idiopathic is we're one of a number of Aboriginal Health Access Centres across Canada, and the Aboriginal Health Access Centres are really about blending together Western and traditional ways of knowing and being to support our folks in their health and well-being, because I feel that it really has the making of an international best practice. Here at the center, we are able to service Indigenous people as a priority. We also service those people who are marginalized and need support who are not Indigenous. They are welcome into our space for specific programs. We service 3 communities, so when we're servicing people, we have to be cognizant of where they come from in the country, what their cultural beliefs are, and they're not always traditional. So it's always a balance, trying to figure out how to offer the appropriate support at the appropriate time to the right people. We want our next generations to be very strong, be very successful, and be very healthy.
Well, thank you so much for the time you spent with us today explaining about your health center.
Thank you so much for working with the Idiopathic. It's a real pleasure.
Thanks.
And me much.
What a beautiful video. And a lovely place to go visit. Thank you so much. That was lovely. You talk about a great deal about community engagement, and from a pediatric or child health sort of standpoint, can you speak to the involvement and the importance of family as well as the broader community in the work that you're doing?
I'm going to combine this response with the question that came in about using a patient story. I was lucky to visit the South Central Foundation in Alaska. I was taking some training on their model, their NUCA model of care. And I was it felt really good to know that most of their training are practices that we've already adopted in our health center about patient relationships and storytelling. And I'll share a story with you that I use when I meet with some of the medical students at the university here about using the patient story. A patient can come into the clinic. It could be a diabetic patient. Diabetes is uncontrolled. He's having problems with his eyesight. And we try to avoid using the formal way, I guess you're trained about patient, subject, plan, outcome. And we listen to the patient. It doesn't take much more time, but just to know when you come in the pleasantries that you use when you do your greeting, and you know that the grandfather loves his grandchildren. He is teaching them to hunt or to fish, and you know that his diabetes is uncontrolled and how it's could affect his eyesight. And to use the approach to say, I know how important it is to you to be able to teach your grandchildren how to hunt and fish. Let's talk about your diabetes and how we can work together to get your diabetes under control. It takes the same amount of time, but you're using your patient's own words, the stories, the things they tell you as you're walking into the clinic room as part of care. And it creates a trusting relationship. They know you've listened to them. You know that the words that you're using as part of partners in their healthcare is guiding as a partner and not being as a directive. You telling them what to do and that it's out of control, and what are you going to do to get your diabetes under control, instead of our approach is how can we work together, and your grandchildren are important, and family units are important. We'll bring the whole family in, again, because relationships are the foundation of how we provide service.
Thank you very much. Both of you, for that beautiful video and your very important words. Finally, for our last presentation today, we have Dr. Karine Topang, April. Dr. Karine is an associate professor in the School of Rehabilitation Sciences at the University of Ottawa and is affiliated with the Children's Hospital of Eastern Ontario, or CHEO, as we finally refer to it, Research Institute. Her work has included research in pediatric and adult rheumatology, with experience in conducting systematic reviews and developing patient-reported outcome measures, clinical practice guidelines, patient decision support interventions, and self-management tools. She's the editor of a Cochrane Musculoskeletal Group and the chair of ACT, Outcome Measures in Rheumatology, Shared Decision-Making Working Group. Today, she'll be sharing the JIA Option Map, a web-based patient decision aid for pain management in juvenile diabetes. Take it away.
Thank you so much for allowing me to present today. So I'll share my screen. Okay, so you should see my screen now. So young people with juvenile idiopathic arthritis, or JIA, often take medications in order to control the disease. So in order to control the inflammation in their joints. However, they may still have pain. And so it is important for them to be able to take the best decision possible about pain management. Our research team developed the JIA Option Map. The JIA Option Map is an interactive, web-based patient decision aid. It's designed to help young people. And so by young people, we mean teenagers as well as young adults, as well as their parents, to make better decisions about pain management for juvenile arthritis with their healthcare providers. And so the app provides evidence-based information on a wide range of treatments. So this includes medication as well as non-pharmacological options. So the goal of the app is really to help prepare young people and their families in order to make the best decision possible with their healthcare providers. So really making a shared decision. So we actually conducted a few steps in order to develop this web application. So first of all, what we did was review the literature and do interviews in order to see how young people with juvenile idiopathic arthritis make decisions for their pain. How do they decide which treatments they're using? And also, in order to determine what are the needs. So how can we help them to make the best decision possible? And so it really came out that there was a need for web-based patient decision aid. So a tool that would give information about a wide range of treatment options. Also a tool that would help them to clarify and think about what is truly important to them. So their values and their preferences. And also a tool that will help them to communicate with their healthcare providers, to really bring pain management discussion into the clinical consultation. And so we really, there was a need for a tool like the JIA option map. Then we actually looked at the scientific evidence for these treatments for pain management in JIA. And so we looked at the evidence, and then we integrated the evidence into the tool. So with consensus meetings, surveys, and interviews, including young people, parents, as well as clinicians and researchers, it helped us to develop and test the acceptability of the paper prototype. So first we had a paper version that was like many, many pages long. And then after that, we developed the web application. And so we then tested its acceptability and its usability. So is it easy to use? Does it make sense for patients? So then this is the JIA option map. And so you can see here that there's 5 steps, and you can see some of the steps, and I'll go a bit more in detail to show you the steps. So first of all, step 1 assesses the intensity and the location of the pain. It also asks what kind of treatments they're using, as well as how they're using these treatments and if they're effective. So if they find them helpful. Step 2, which is here, step 2 asks what is important to users. So what is important to them? Is it more important to them to really relieve pain immediately, so as quickly as possible? Is it important to avoid taking pain medication on top of their arthritis medication? Do they prefer to use treatments that help them to relax or help them to be physically active? So everybody will have their different preferences. And so this step asks these questions. Step 3 provides a few different treatments that they could try on their own right now. And it also provides a list of a few treatments that they could discuss with their healthcare providers. So often these treatments will be medication or treatments that need a reference, for example. So they can't just really go on their own and use it. It wouldn't be really safe. These treatments are shown based on where they have pain, their preferences that they put in step 2, as well as scientific evidence that we gathered. Users can view also all 39 options. So here it's their results, but they can have the 39 treatment options, and they can actually select the treatments that they like the most and bring them into their favorites. So this is an example of how what the evidence looks like. For each of these treatments, we give information on what experts suggest according to clinical practice guidelines. We also give information on different studies that were done on the treatment. And we also provide links to other to websites and to apps that could help them to get more information. So step 4, ask users to make a personalized plan. So based on their favorite, they can decide which ones they want to try right now. And it also shows suggestions to address barriers to following the plan. So what would get in the way of actually following the plan? Step 5 is a summary. And so it shows all the information that the users entered in the app. And they can print that summary or save it on their device. And then they could show it to their healthcare providers to start a discussion. So users can log into the app over time. So they can log in a few times a day, like I did this morning. Or they can log in a few times a week or a few times a month. And then they can monitor their pain and their disease activity to see what treatments actually seem to work better for them. So young people and parents who use the JIE option map with us mentioned that it was easy to use. They also said that it helped them to learn about new treatment options that they didn't know about. They felt that it also helped them to understand what was truly important to them, so their preferences and their values. And they felt that the summary would help them to have a more comfortable discussion with their healthcare providers. So thank you so much for allowing me to present. And if you have more information, if you want more information, please reach out to me or to the team. And I would like to thank the Chronic Pain Network and all the funders, as well as the whole team. And I think I probably am missing some people there. And also the people involved are the patient partners who are really, really important in this endeavor. So thank you.
Thank you so much. Question for you. How did you modify the how you did the research project and its outcomes?
So we work with patient partners. We have a patient partner committee. And so over time, we definitely changed some elements. I mean, we changed the JIE option map. We did a few versions, right? We did like 3 versions. Now we're at the 3rd version. We also decided to add, we also decided to include young adults, because at the start, it was really aimed more at adolescents. But we really realized with all our patient partners, they were really saying that once they transition into adult care, they really don't have a lot of information. So it's even harder to make decisions. And so they really felt it was a very important population. And so we actually added young people, like young adults, to our population. And it seems to be maybe the ones that may use it even more. You know, also parents seem to use it more. Yeah. Adolescents often don't want to read everything. They're kind of, they want to go quickly. We see that often.
I'm particularly pleased to hear about the focus on the transition to adulthood, because there's often a vast change in the nature of services provided once that transition happens. Sometimes surprising, shockingly to some families.
Yes.
Thank you so much. We've got a couple of questions from the audience that I will pose now. Gashan has asked, and this is for Dr. Berg. You responded in the chat box, Dr. Berg, but it was only to hosts and moderators. So I'm just going to give you a chance to address it to the whole group. How can you explain the delay of diagnosis 6 months with severe symptoms?
Right, and it's difficult with the data set that we have to fully explore that question. We will be doing more analysis, but things to look at would be, did the number of referrals prior to diagnosis maybe delay diagnosis, or are there certain characteristics among those patients with certain signs or symptoms that maybe are harder to recognize? So it's a great question. I can't answer it specifically at this time, but there was a real marked spread in the time to diagnosis. Some children are diagnosed very quickly, and others waited quite some time. So I think there might also just be difficulty in recognizing those signs and symptoms and getting to somebody that actually recognizes them for the patient, perhaps focusing on the original injury and not recognizing that more is going on.
Again, with more study becomes more questions to answer. A question for everyone or anyone who wants to respond is, how has COVID affected this work? Anyone?
Maybe I can answer. So for us, it was really, there was a lot of delay because of COVID. I mean, for us, it really kind of stopped recruitment in the hospital setting. So for us, we really had to go to social media. And it was actually kind of a saving grace a bit that we added young adults, because young adults are really kind of very engaged in social media. And I think very engaged for their health and for looking at research projects. So I find for us, it really helped because teenagers were harder to reach, we found, with social media. Maybe just they want to have fun only.
Thank you very much. A few of you have talked about web-based or technology-based practices. With COVID, did you see a trend towards the use of virtual care? And how do you anticipate it will impact pain management moving forward? And this is, again, for anyone who would like to answer. That's okay. I'm fine with silence, but I'm also okay to move on given the short time. Wante Che has asked, did you have tools to reassess pain control for its effectiveness after your administration of opioids? Wang Te didn't identify a particular speaker, so I'm open to whoever wants to take it. It's okay. Nicole Pope has asked, for the digital health intervention or apps, she's wondering about what work is expected in maintaining or updating of the app. And do you see any scope or need to have these apps integrated with EMRs, for example?
Yeah, I'm happy to answer that question. That's a great question, because one of the challenges of using technology is that it's constantly changing. So just keeping everything up to date is definitely something to keep in mind in terms of your budget and your project planning. So for iCanCope specifically, one of the reasons that we partnered with University Health, and I work as our development partner, is that we have an agreement with them to keep the apps up to date in terms of the latest updates to iOS and Android. Currently, the scope of iCanCope is as a self-management app. So we wanted to leave all the data in the control of the patient. Although the way that the product is built, it's built on the FHIR kind of foundation. So it does have the technical capacity to be integrated with EMRs in the future if we choose to go that route.
Oh, great. Well, that brings us to the end of our time today. I want to thank you all for your time and sharing your time and expertise with us. We really appreciate it. Thank you to Skip and our 6 fabulous presenters for sharing your time and expertise with us today. Thank you to all our members and other attendees for choosing to join us. We know how busy you are right now, and we hope you depart with some practical knowledge to bring back to your organization. We are almost at our year end here at Spark. Join Children's Healthcare Canada tomorrow at 12 Eastern for a Mental Health Network webinar on Kids Help Phone, using data, innovation, and digital solutions to meet the mental health needs of youth in Canada. And on December 1st at 11 a.m. on Spark Live for Boosting Children's Literacy. You can do it and we can help. We are also just 5 days away from Children's Healthcare Canada's annual conference with this year's theme, From Crisis to Catalyst, the next chapter for children's healthcare. It's not too late to register, and do so at childrenshealthcarecanada.ca. And it's always great if you watch live, as your questions and comments really enrich the discussion. But if you cannot, the recordings of these sessions are made available after the fact on our Knowledge Exchange network. So thanks again for joining us today. Thanks to Dr. Solatani, Berg, Lalu, Latimer, Topin, April, and Angela Navo for sharing your time and expertise. And hopefully we'll see many of you back here on December 1st for our next Spark Live webinar. Bye, everyone.